Jean-Luc, so it's my task to discuss with you the case of a patient with asymptomatic patient. So I will first present you the history of this patient. So it's a 63-year-old man patient with a past medical history of an acute coronary syndrome a few years ago. It was one vessel coronary artery disease treated by stenting of the left anterior coronary. He had also a history of hypertension and is knowing like a story of bicuspid aortic valve, but nothing is really well known. He is coming at the outpatient clinic for follow-up of the coronary artery disease. He does not complain of chest pain. There are no chest discomfort, no shortness of breath, no palpitation. He lives in an apartment in the 5th floor and stops just one when going up using the stairs. So you will agree with me that he is asymptomatic. His treatment is aspirin, beta blocker, ACE inhibitor, and statin, and at this time he's taking some ibuprofen for muscular pain at the level of the legs. So the patient physical examination showed quite a weight of 77 kilo. Blood pressure is 130/90. You have a grade 3 systolic murmur with a preserved S2, some quite hypertension, and the rest of the physical examination is unremarkable. EKG is also unremarkable. But let me show you the echo. This is the power.
You just mentioned that the S2 is preserved. What does this tell us?
So you know, sometimes I use my stethoscope, and you can say that when you have a preserved S2, you can say that it's a sign again severe stenosis. When you lose totally the S2, you can say it's a severe aortic stenosis. Of course, as all the signs that you have by listening to the heart, the sensitivity and the specificity is quite low, but maybe you have to know that. So this is the parasternal long axis view, and I draw your attention on the aortic valve and on the aortic rod. So close view, you see that there is some degree of thickening of the valve, maybe some calcification. There is also some degree of aortic regurgitation. Short axis view of the valve, I can confirm it's a bicuspid aortic valve. It's a type 1 with a RFA at this level. Going to long axis view, and I will go, this is a long axis view showing some degree of calcification, port opening, and some regurgitation. So this is the result of the measurement, and I can confirm that you have a peak gradient of 65 millimeter, mean gradient 36, and aortic valve area of 0.82 centimeters square. So we are in the criteria of the severe aortic stenosis. Of course, we try several approaches to have this gradient, but the maximal gradient was obtained by the apical view. So this is the summary of the function, and you will see that this patient had an excellent function. So my first question is, what would you propose to this patient? First, it's nothing, because you are also short of breath if you keep 5 floors. You will suggest that the patient comes back at 6 months for new assessment. B, you are not happy with the result and you will have more information. And 5, you send directly the patient for the surgical aortic valve replacement. Please vote no. And during the time that you are voting, I will ask the advice of the panel on the echo appearance of this aortic valve.
I just wanted to ask you the question. Your valve area is clearly in the range of severe AS with 0.8. But peak velocity is just 4 meters per second.
Yes.
And the mean gradient is just below, so rather of borderline severity. And when you look at the valve, it's clearly calcified, but it looks like it opens a bit. Can you comment about that? Is it reliable when you see the valve opening?
I would like to remind you that it's a bicuspid aortic valve. So in bicuspid aortic valve is frequently a pyramid for you or dome for me opening. So it's like that. And if you look at this level, you will have the impression that it's still opening. If you cut at this level, you will have a narrowed opening.
So in other words, it's not reliable to look at the valve en face view. Yes. You can have a wrong impression of opening.
It's always difficult to know on the 2T echo exactly at which level of the valve you are.
Okay.
If you go to 3D, maybe it's easier.
Yes. I would agree with that, and especially in bicuspid valves, if the valve is less calcified, it sometimes looks as if the valve would open and would be more pliable. But if you measure the separation, it is frequently in the range of 8 to 9 millimeters only, and this will tell you that severe disease is still a very plausible option.
Okay.
So we go to the result of the
Marisa wanted.
If I may comment, actually, if you have a good image quality, you can also take a 3D data set and to cut the valve above and to look from the other side, from the aortic root perspective. And sometimes, because you don't have the through plane motion, you are able to see exactly how much it opens.
Yes.
Okay.
So let's have a look on the result of the word. So 1/3 will do nothing, and 2/3 will go further, have more information. So if you look at the guideline from the ESC for aortic valve replacement in asymptomatic patients, you see that it should be considered with normal EF and non-exercise abnormality if you have severe aortic stenosis, or if you have severe calcification or transvalvular velocity more than 0.3 per year. So we are not in this setting, so this is not an indication for this case. So you want to have more information to take the decision. So I can propose you BNP dosage, MDCT, MRI, or exercise stress test with echo. So please give me your opinion.
You probably are allowed to have multiple answers. Try it anyway. I'm not sure of this.
That's why.
Because to me there is not only one good answer.
So I think that you may have different information from the different tests. So one part, 19% will have a BNP dosage. I can give you the BNP dosage. It's 39. We say that it's the normal range. Nobody want to have, yes, 3 people want to have MDCD. Nobody want to have MRI, and the majority want to have exercise test with echo. Maybe it's because it's the title of the session. So MDCT will still have some interest, because you can't have a look on the calcification on the valve and say if it's heavily calcified, it's an argument to say it's a severe aortic stenosis. One other point is that I would like to remind you that we have a bicuspid aortic valve. So there is some interest to have a look on the aortic road and to see if there is some dilatation. So you have some advantage to practice MDCT for this aspect, or you do an MRI for the aortic road, but you lose the information about calcification. So, is it some interest for doing exercise echo? If you look at the guideline, you will see that the aortic valve replacement will be indicated in asymptomatic patients if you have symptoms related to aortic stenosis during exercise, or if you have a fall in blood pressure, or if you have asymptomatic patient with severe aortic stenosis, normal EF, and that you don't have the finding, or you have one or more of the following findings. It's markedly elevated BNP, it's increase in mean pressure with the gradient by exercise over 20 millimeters of mercury, or excessive left ventricular hypertrophy. So this is the hemodynamic part of the exercise, and you see that the heart rate increase, and that we reach 82% of the maximum predicted heart rate. The patient was on beta blocker. If you look at the blood pressure, so you have quite an increase, but during the 3 last steps of the exercise, the pressure is maintained. And the patient stopped because he was exhausted. If I show you the ECG trace, you see that there is no change at peak exercise. So in summary, the patient at a workload of 120 watts, heart rate going from 85 to 130, it's 82%. Blood pressure, it's going from 154 to 200 with 110. EKG is normal, there is no symptom. So we have an exercise test with no symptom, no fall in blood pressure below baseline, no station, no arrhythmia. So we cannot say that we have one of the criteria to be positive for this stress test. So what will you propose now to this patient? So you will propose nothing. You will suggest that the patient come back in 6 months for new assessment. Or you will send the patient for surgical aortic valve replacement, or because you perform exercise echo, you will have a look on the echo data. So vote, please.
While you're voting, I will just briefly come back on MDCT, CT scan. It's really, really important, a crucial exam for this patient for 3 reasons. First, you can quantify calcium based on the works by David Mezikazetu and the group of Vahanian. You have really a prognostic impact on the quantification on calcium in these patients. Second, the aortic root, as you said, and third, you can also have the coronary anatomy. So
yes.
MDCT is crucial in this setting. Can go on.
So if you look at the result of the vote, I think that it's quite very discussed, because 55% will send the patient back home, and 42% will look at the result of the echo. So I propose that we look at the result of the echo, because you still perform the examination. So.
Did you forget the title of the focus?
So this is the result of the echo. This is the baseline data. So as you know, peak gradient 65, mean gradient 36, EF 60%. Just show you the result of the PICS exercise. So you go to 93 millimeter of mercury peak gradient, mean gradient it's 58, and EF increase.
So I think this is very interesting to look at the Doppler curves at this stage. You see that there's obviously an increase in heart rate during the exercise stress. So the systole is shorter. It seems like a steeper signal, a shorter signal. Does this finding may have an impact on the mean gradient without affecting stroke volume eventually?
Of course.
This is the same issue in mitral stenosis. Of course, during exercise, heart rate increases, and in this case, the systolic ejection period decreases, and probably in a way it participates to the increase in mean gradient. We'll let you go on.
I agree. So in summary, I have already shown you the result of the hemodynamic part, and from the echo part, you go from a mean gradient of 36 to a mean gradient of 58. What is a difference in mean gradient of 22 millimeter of mercury? So if I go back to the guidelines, and you see that AVR might be considered in asymptomatic patients with severe aortic stenosis, normal EF, and none of the above mentioned exercise test abnormality. If surgical risk is low, we calculate the Euro score 2 of this patient, and it's at 0.55%, and at a normal coronary angiogram, we don't see any exercise abnormality. And the second part, it's one of the following findings is present. And there is an increase in mean pressure gradient with exercise above 20. This is present in your patient, so we can consider that it's a class 2B indication. Moreover, if I show you some slides on the world of exercise echo, and this is from a study from Lancelotti published in 2005, and you will see that the prognosis of patients with an aortic valve area above 0.75 is far better than below 0.75, but this is just rest data. If we add the exercise data, you will see that if you have a normal exercise test, you have a good prognosis. If you have an abnormal, you have a worse prognosis. And if I put the echo data on the top of that, you will see that if you mean pressure gradient difference is below 18, your prognostic is good. But in the opposite, if it's greater than 18, your prognostic will be quite poor. Oh. And in fact, this echo value adds some additional value if you try to predict the score of your patient. And this was confirmed by another study by Sylvestre Maréchaux, published in 2010. So at rest, we can say the same difference. If you have a mean gradient below 35, you're good prognostic. Above, you have a poor prognostic. And you can find exactly the same with the exercise difference in gradient. If it's above, if the difference in mean gradient with exercise it's above 20 millimeter of mercury, you have, of course, a worse prognosis. So if we put both together, you will see that if you are in the category of the rest mean gradient above 35 and a change with exercise in the mean gradient above 20, you are really a poor prognosis just for 2 months. And this is the case of the patient that I just present you.
And yes, I think Raphael has a comment.
I would have a question, because in this study, the resting gradient is clearly in the range of moderate stenosis. It's 35 millimeters of mercury. How would you interpret this limitation? Because I think we do not want to operate on a patient with moderate stenosis. I think the patient you present, based on the fact that the peak velocity is 4 meters per second and valve area is small, puts him into the category of severe stenosis anyways. But is the threshold of 35 meaningful in risk stratifying?
Yes, it's true. You're totally right. This study includes a part of patients with moderate aortic stenosis, but it's the cutoff coming out of the study. So maybe it's not exactly the same, because if you look at the other study, you can find that the mean gradient of the cutoff, it's different according to the study. So I will say that there is not yet a definitive gradient. So
I think we also would have to look at the distribution of the patients. It could just be that there are 2 patients between 35 and 40, and still if the cutoff is arbitrarily chosen. So I think I would have been would feel more confident in studies just including patients with severe stenosis at baseline.
That's true. You have a point.
Last question on your patient, Agnes. Did you calculate the calcium score in this patient? And how?
Yes, it was above 2,000.
Above 2,000. Okay,
2,100 and something.
Supportive of severe aortic stenosis. More than 2,000 for a man, it's
yes, and in fact, what I didn't say you is that we perform, in fact, both MDCT and MRI, but it was for study purpose. It was not for the clinical evaluation, and both confirmed the presence of quite severe aortic stenosis. So now, if I ask you for the final vote, what would you propose now to this patient? Still nothing, you will suggest that the patient come back in 6 months for new assessment, or you will send the patient for surgical aortic valve replacement. So I will ask you your advice now, please vote. So this is a young patient, 63, sorry, age quite
very
active.
low operative risk, but operative risk is never 0.
No, it's never 0, but if you drive your car in Paris, it's never 0. So I see that 58% we send the patient for surgery and 37% we see the patient. So what we did, of course, we had a discussion with the patient and we had a discussion with the ARC team. And we decided to propose aortic valve replacement with a bioprosthesis. And the surgical inspection showed a unique speed valve with 2 referee. And in fact, one of the points is the wish of the patient, because this patient is young, quite very active and traveling a lot, and say, I want to have my problem solved now so I can continue my life. And it's true, he's doing well and traveling all over the world now. So I thank you for your attention.
Thank you. Thank you very much, Agnes. So now we have reached one of the key points of this session. You have understood that this case is controversial. This patient had severe aortic stenosis, but not very severe aortic stenosis. And at the end, every case is unique. And the fact that the patient wanted to travel all over the world was really a strong argument favoring surgery.
I want to add something, because the result of the normal exercise test in this patient actually was excellent. So he didn't have a blood pressure drop and had a very good regular exercise test. So it is clearly one element, but probably the factor that could tip the decision is his wish to be independent. And if that wouldn't have been the case, I personally would have opted for a more conservative approach. I don't know what you would have done.
Denisa, do you have a comment on this? On the other hand, if to defend exercise echo, the fact that exercise testing was normal is a strong argument for looking at the Doppler variables, if it aids. What do you think about that?
Yeah, I think you're right. It's never easy to take this decision, and I think also the patient will, it's important to take into account in these cases which are not very clear, and the surgical risk was very, very low. Probably the experience of the surgeon is important, and if you are sure that the surgery can be done with the lowest risk, you can opt for an earlier surgery.
But we have to keep in mind this is one class 2B criterion at the present stage. So elements are important. If, in addition, the BNP is a little bit more elevated of the patient. So there are several factors here that I think should be integrated in the decision making.
But it's quite a young patient. I think that if patient has been 75 or 78, the decision will be different.
Okay. Thank you very much, Agnès. So